Good afternoon. Hi, I'm Bill Coase. Welcome to our BVHS Live and Learn. We're going to be talking today about basically treatment for breast cancer. Just a reminder, if you do have questions, send those in over the chat. We'll try to get to and answer all of those that we can. Also, we're open for suggestions. This may be a continuance later if we don't get to cover everything. And in addition to that, there will be a survey that we'll provide at the end. Planning on being here about 30 minutes to talk about the concept of breast cancer. I have with me two guests that are related to the cancer program that we have here at BVHS. And Adele, why don't you introduce yourself, and then I'll ask Dr. Browning to introduce himself. Tell us a little bit about yourself, what you do, and how long you've been at BVHS.
Okay, thank you, Dr. Coase, and thanks for having me here. My name is Adele Simon. I'm a registered nurse. I've been in medical oncology about 13 years, and I've been with Blanchard Valley since about 2015. I'm also the clinical office manager at the Arms Family Cancer Care Center. We're a division of Blanchard Valley Hospital on the Eastern Woods campus. Our programming includes medical oncology, infusion therapy, radiation oncology, radiation therapy, and patient care and support services.
Great. Dr. Browning, my friend.
Yes.
He's been here almost as long as I have.
Less 10 years. But it's been a long time. So my name is Eric Browning. I'm one of the breast surgeons we have here at Blanchard Valley Hospital. I started my medical career with medical school back in what my grandchildren refer to as the past century. And I finished my residency in 1985, and I've been at Blanchard Valley Hospital ever since that time.
Eric, well, let's start with just maybe some facts, a few about the incidence of breast cancer. I mean, I can remember we certainly made the diagnosis a long time ago. Things have changed a lot. Are we seeing more of it? How prevalent, et cetera?
Actually, the numbers are pretty remarkable. If you just start off with the number of women that have cancer of any kind during their lifetime, it's 1 in 3. So you pass women on the street, 1, 2, 3, 1, 2, 3, 1, 2, 3. Every third woman is going to have had cancer sometime in their lifetime. Of those cancers, the most common is going to be breast cancer. So again, a remarkable number. 1 in 8 women sometime during their lifetime is going to have a breast cancer. If you have a mother, a sister, or a daughter who has breast cancer, your chances of having breast cancer go from 1 in 8 to 1 in 4. And you talked about the incidence of breast cancer. Those numbers are actually slowly rising, but those numbers are somewhat counterbalanced by the improvement in survival rates. Over the course of my career, survival rates have increased by probably 45%, to the point that now if you have a cancer that is a stage 1 cancer or a cancer that's confined to your breast, your 5-year survival rate is going to be about 99%. That's pretty remarkable. If your cancer has moved to the regional lymph nodes that surround the breast, or a stage 2 cancer, chances of surviving 5 years is not quite as great, but about 85%, still, again, a remarkable number. Unfortunately, if your cancer has spread beyond the breast or beyond the lymph nodes and settled and created new cancers in some distant organ, your brain, your lungs, your liver, now it's a stage 4 cancer. Now your chances of survival of 5 years drops to about 30%. So even though a lot of great progress has been made over the course of my career, we still have a long way to go.
And we will be talking about that, how important it is. It makes just good common sense that you want to find that early. And I think one of the other points that you made, Eric, so we talk a lot about genetics, and certainly if you have in your family history, and you've talked about that, but still a lot of individuals, there's not any family history, and you can still get breast cancer.
That actually is the majority of women that I see in my practice, or across the United States. Is that lots of women assume that my risk of having breast cancer is the risk that I had someone in my family with breast cancer. But in fact, the majority of women have no family history of breast cancer, and a lot of times they are absolutely stunned. I could not possibly have breast cancer. No one in my family has that, but in reality, that's about 80% of women.
Yeah, it's not, and I can just personally say my sister died of breast cancer, and there was no one in the family that we knew of before or after. So just it's something to remember that the safety of this is related, not just with a family history. So Adele, let's start. Let's just start. Somebody has breast cancer, okay? That they come in. What's the plan? What do we do when that diagnosis is made?
Well, when you first get that diagnosis, you're going to receive a lot of information. It's going to come from your providers, your physicians, your family, your friends, sometimes friends of friends, or the internet.
It's going to come from the internet. Yeah, okay.
From the internet. So it can be a little overwhelming. It may be scary. You may not know where to start or what to do, and that's okay. If you receive that diagnosis at the Eastern Woods Outpatient Center, you're going to meet with a radiologist, but you're also going to meet with an oncology nurse navigator. She's going to become that point of contact for you for any questions that you have during that cancer journey. She's also going to start the education, start the support of your team. She does education on what breast cancer is, how it behaves, how it's treated, but I think most importantly, she's going to talk to you about your specific breast cancer. She's also going to help you start to build your treatment team. It's likely going to include a medical oncologist, radiation oncologist, a breast surgeon, and you along with that care team will ultimately decide what the treatment path is going to be.
So a plan is designed individually for a person, and who sits down and talks to the patient about the diagnosis when it first occurs? That I assume could come from different places?
And definitely. Your radiologist is going to talk with you initially when you're at the Eastern Woods Outpatient Center with your oncology navigator. That navigator will then help you build the care team. And when you are with that treatment team, they're going to continue the education process. They want you to be able to have an informed decision about what your treatment is. They're going to present options, and it's going to be the good and the bads of those options. But it's going to be something you can build into what's going to fit your unique needs. It's going to be individualized, but then it's also going to be rooted in evidence-based care. We want it to be something that's based on research, scientifically supported. In our community, we have lots of providers that have expertise in providing breast cancer care. They have access to state-of-the-art techniques. They also have access to clinical trials through the National Cancer Institute that they can talk with patients about. These could be treatment trials or ones to improve quality of life. Ultimately, your treatment team, it's going to be providers, nurses, other health professionals, and support staff. They're going to be the ones that sit down with you each day and talk with you about your treatment plan and your unique needs.
Okay, thank you. Well, Eric, so a diagnosis has been made and a lady comes to see you. I assume most time starts with a surgeon, could be someone else, but how do you approach this?
I think more commonly it starts with us, but not always. And again, like Adele mentioned, the education part is critical. For patients to be able to put together a treatment plan for themselves, they have to understand how cancers work, and we start with the very basics of, this is what a cancer is, and it's surprising the number of people that know that cancers are bad, but they don't understand how cancers behave. So if you're going to fight the enemy, it's best that you understand sort of what motivates the enemy and what their, not only what their threats are, but what their sort of opportunities to fight them best are. And so we start with cancer in general, and then we focus a little bit more on breast cancers more specifically. And then finally we get down to the individual level, because everybody's cancer is separate and distinct, and they have different vulnerabilities and different threats. So we get to that point. So education starts. I like patients to, if you're going to make a plan for yourself, you have to understand what your choices are and why some choices are good and some choices are bad.
And so how do you approach that then once you have done some education? I know this is not a 10-minute appointment. I know that you spend a lot of time sitting down and just talking to someone, and can't overemphasize how important this is. This is obviously a game changer to someone when they hear the C word, cancer, and what happens. So what's your approach then if we're going to look about surgery?
So again, my talk usually takes between an hour and a half and 2 hours. And it starts with, again, with the basics. And we learned that this is actually, for most women, a two-part problem. There's a part that surgery plays the biggest role in, and that's control of the cancer in the breast. Sometimes that includes radiation therapy, which is also important in controlling cancer in the breast. But the other part of the equation, and probably the more important part of the equation, is, has this cancer spread other places in my body? And we saw that in those survival numbers, in that cancer that's confined to the breast or the regional lymph nodes has an excellent prognosis, but if the cancer has spread someplace else, then the chances of survival drops precipitously. So again, my job as a surgeon is to explain to patients what role surgery plays. And because surgery and radiation are, those two things are interconnected, I'll touch on how radiation works. And then, because this is also interconnected with medical therapy, how does local control affect systemic control or treatment of the rest of the body? We'll touch base on that. But again, my emphasis is on surgery. I understand surgery well. I understand radiation therapy a little bit, and I understand medical therapy a little bit. And then you see those experts. I don't tell people what kind of radiation they have, and I don't tell them what kind of medical therapy they're going to have. But it's important that we coordinate our care.
So one of the points is that there's a lot of teamwork. I hope everyone is hearing that. This is really important for continuity. And I'm going to ask you a minute, Adele, just where's the navigator get in talking, and I'll ask Eric to talk a little bit more about surgery. Do we have any questions from the audience? Jen?
We do, actually. There's two questions. One around when you have an appointment, when would that be scheduled? And then two, another question came in, and we can do this one first since it's about surgery. After having a mastectomy from breast cancer, is there a particular type of reconstructive breast surgery that's, quote, more safe?
So we're going to be talking about surgery. One is about reconstructive, if someone has mastectomy or some kind of surgical intervention. So let's just talk about surgery in general, and then we will get to that, and then Adele will make sure that we come back about the appointment.
Okay. So surgery in general, again, the biggest threat for cancer is that the cancer escapes from the breast. Cancer cells lodge in some distant organ and create new tumors at some distant site. So that process is the cancer has the ability to invade blood vessels. Once it penetrates into a blood vessel, cancer cells break off and are swept downstream in the bloodstream to other sites. The goal of surgery is to arrest that process before that's happened. So back when I was a medical student in the last century, that discussion was very brief. You know it well. You're going to have a modified radical mastectomy. It was a short conversation, but it wasn't a very sweet one. By the time I finished my training back in 1985, we were starting to get a little more confident that you could remove the tumor and preserve the breast and still end up with the same outcomes. So if the tumor is large and occupies a greater portion of the breast, your choice is still going to be a mastectomy. If your tumor is smaller and occupies a smaller volume of the breast related to its overall size, there is at least the opportunity to preserve the breast. So most of the women I see today do have that opportunity, and their question to me is, well, medically, which is the best answer? And I think what they're really asking me is that if a little bit of surgery is good, is a lot of surgery better in terms of survival? And that's an easy answer. As long as the tumor is gone at the end of the operation, it doesn't make any difference whether you have a little bit of surgery or a lot of surgery. So sort of at the base level today, your choices are, for some women, for most women, an opportunity to preserve their breast, and for some women, a mastectomy. Now, for whatever reason, for biases and preferences, there are women who are candidates for breast preservation, but some still opt for mastectomies.
Yeah, maybe we can come back to restoration after we've talked about some of the other modalities that may be looking at this, going back to we're trying to individualize a plan, and I don't know that it would be so obvious, but if you have disease in other places, that may need to be taken care of before you think about reconstruction. So, Adele, the question, I think, was how soon can you get an appointment if once a diagnosis is made? So maybe just the timing of what happens. This is not, if I had breast cancer, I don't think I'd want to get an appointment in a month or so. So how do we go about, there's a lot of angst. Dr. Browning's talked about that. What's the process?
Well, and I think we've mentioned this many times with breast cancer in general. It's very individualized. When our patients meet with that oncology nurse navigator, we like to start the process right then. Some patients are very willing and have a really good idea of who they want to see. I want to see this medical oncologist. I want to see this surgeon. Some people would like to wait. They want to get some input from maybe their primary care provider or maybe some family or friends, somebody who's maybe been through the process before. And then the navigator will reach back out and help with any of those referrals. What does happen at that first appointment, if the patient is ready to go ahead and make some decisions on providers, those calls are made right at that time. That breast cancer navigator is, calling over to maybe Dr. Browning's office and talking to someone in his office about what times you have open to see this patient. She's calling over to the Arms Cancer Center and trying to find an open slot there. Obviously, if there are some questions about further testing that may need to take place, maybe a breast MRI, or more information that has to come out, the radiologist that's there will help with that and help guide more information. Also, there are some things that would come back from pathology, some further, you could say, pieces to the puzzle that might need to result before a treatment plan could be made. So it is very individualized, but we start the process as soon as possible.
So it's a work in progress. We are continually adding to that. And it would sound in general that would be up to the patient about how, I don't want to say fast we move, but those kind of things. And the contact person is a navigator. So you have a personalized individual that you can contact to ask questions about, which again I think is really important, I think, our experience.
I would say from the surgeon's standpoint that the navigators have our cell phone numbers. And that
great point. Yeah.
We understand the anxiety that is immediately provoked by a diagnosis of cancer, and at least from the surgical office, our goal is to get patients in within 3 days of that phone call. And sometimes that means that we don't have all the information that we need to actually formulate a treatment plan, but I think it's really important to see women early and to tell them that there are great options, and again, the education part is critical, and we can start that process right away without even having all the information at the first visit.
That's a great point. The whole navigator idea of chronic diseases, but especially with cancer, and we have several individuals that are well trained and know how to do that. Jen, another question?
Sure. A couple came in here. Can a patient receive radiation here in Findlay?
So the question was about radiation. So that's another modality that'll just segue into that. Eric, we've talked in general about surgery and what a surgeon's going to do. When does radiation get involved, and why would they get involved?
So the answer to the question is yes. That's an easy answer. And actually, probably 75% of the people that we see have some type of radiation in the course of their treatment. And again, in the public side, a lot of times radiation treatment is sort of paired with chemotherapy, but that is not the pairing that we see with breast cancer. We're pairing radiation with surgery. So I know that at the end of an operation, I think that the cancer has been completely removed or ablated. But I also know through long and bitter experience that no matter what kind of operation you have, how minor it is or how extensive it is, there's still a chance that cancer cells have been left behind and will pop up like weeds at some later date. Now, that chance may be as small as 2 or 3%, or it may be as high as 20 or 30%. Radiation therapy is sort of like weed be gone for the breast. You might have left some weeds behind, but if you apply a little bit of radiation therapy very judiciously, you will dramatically reduce the chance of those weeds springing up later in your lifetime. So it's really, I mean, it makes it sound really simple, but it's also probably the most complex thing we do. You know, it involves linear accelerators and highly energized subatomic particles and a bunch of physics, which I don't get along with very well. And it involves probably the most advanced technical equipment that we have, the most sophisticated computer programming, and by far and away the most precision that we use in any source of medical therapy. But we are really blessed that this community has those opportunities available right here.
Excellent technology, really good people. And just as surgery has advanced, radiation therapy has made significant advances over the past several years. A lot of technology, as Dr. Browning pointed out.
It's actually replaced, you know, for treatment of lymph nodes. It's you know, starting to replace a lot of the surgery that had taken place in the past. It has fewer side effects, fewer long-term complications associated with it, and I think that maybe not in the duration of my practice that will supplant surgery, but I think there's going to be a lot more radiation and a lot less surgery for breast
especially
cancer
with
in
the
future.
precision, is what you said.
Absolutely.
The side effects are not what you may have heard. The sicknesses and things for all kinds of cancer has been markedly improved. Do your navigators, Adele, get involved in the radiation also as far as making appointments and answering questions and things like that?
They can, but typically we have questions will go directly to our radiation staff. We have radiation nurses that work directly with our radiation oncologists. We have radiation therapists that are educated in that area. So we tend to send those questions to the ones who have the expertise in that matter.
Well, let's move on. So I'm a medical doctor, so we haven't got to the medicine guys yet. It's been all proceduralists. So when does an oncologist get involved, or what I'll say a medical person?
My answer to that is always.
Okay.
So they're not always needed, but they're always called. So again, the big threat is the cancer that has escaped from the breast and presented someplace else in the body. So at Blanchard Valley Hospital, we know that about 15% of the cancers that we see, there's almost no chance that that has happened. We also know that for about 5% of patients, by the time their cancer is actually diagnosed, we have evidence already that the cancer has spread, and immediately, you know, the medical oncologists are involved and they start their treatment planning. The hard part is the 80% in between. We know that for 80% of our cancers, there's at least some possibility that the cancer has spread. And so the questions, you know, arise, well, if it's spread, you have medications that will take care of it, and the answer to that is easy. Yes, we have lots of different kind of medications. So the next question is well, just tell me yes or no, has it spread or has it not? And for 80% of the people, I can't tell you yes or no. So people can say, well, if you don't know the answer and you have medicines, then I'll just wait. And for some people, that's a good bet because their cancer won't show up other places later in life. But for patients who lose that bet and the cancer shows up in their brain or their liver, that's a really bad bet. If it shows up in the liver, the chances of us curing that cancer are nil. Probably is not going to be cured, and they may live for many years with their cancer, but they probably will die with that cancer present. So that's a bad bet. The opposite side of that coin is, well, why don't you just treat everybody? You know, if you can't tell me, we'll just treat everybody. And unfortunately, those medications have costs, and those medications have side effects. So some of the side effects are very arduous, not very common, but sometimes they can be problems that will, hamper patients for the rest of their life. So Treating no one doesn't make a very good sense. Treating everybody is certainly not an option. So our medical oncologists are stuck with the problem of trying to determine what's an individual patient's chance of developing a cancer. And they look at a lot of different things that help them predict that: the size of the cancer, how aggressive does this cancer look, right down to the genetic fingerprint of the cancer, and they'll come up with a number. They'll say, well, your chances of this cancer recurring sometime in your lifetime is 20%. So to say 20%, well, that's 1 out of 5, that's pretty high. If we treat you today with a medication, I can reduce that chance of it showing up from 20% to 5%. That's the good part. And like Adele said, there's no perfect answer. There are some answers that are better than others, but there is no perfect. So the good part is you take this medication, you take this pill twice a day, reduces your risk from 20% to 5%. That's the good part. What's the bad part? Well, the bad part is that there are potential side effects from your medication. So you're going to be a little bit of a gambler. They're going to sit down and tell you, here's the goods, here's the bads, here are the numbers, and different people are willing to accept different numbers. And at the end of the day, our hope is that 20 years later, you don't know whether you're still alive because you didn't need the medication in the first place. Again, 80% didn't even need the medication but took it anyway. Or if you're one of that 15% of people who took the medication and are alive 20 years later because you did. So it's a really hard, really complex, it's the medical doctors.
So it really is complex. And one of the things I want to mention, we're accredited here with American College of Surgeons Tumor Board, that maybe just speak to that a little, Eric. This is not individuals making decisions. I'm really impressed. I sit in and listen. All of these different modalities are there and talk about this. You have specific algorithms that are looked at as far as what the treatment would be related to the staging and things like that. Maybe you can just pass on your feeling. I know you're the head of the tumor board.
Well, it's interesting in that breast cancer is the most studied cancer of all time. More health care dollars are spent on investigating breast cancer than anything else. And you would think that would lead to simple answers. But the simple answers were back in the last century when your choice was a modified radical mastectomy. And if you needed chemotherapy, there were about 2 drugs. The more we understand about cancers, the more complex it is and the more choices we have, the more difficult it is to actually make those treatment decisions. And because all of those things are interrelated, surgery and radiation therapy and medical therapy, it's really important that people sit down together and discuss individual cases and all the possibilities and how they may interact at one time.
And that is good for patient care. Well, we've got still a few minutes. You have a couple questions. Before we do that, though, do you want to say anything more about reconstructive surgery, about what would be available? I think that was a question.
So that is one of the options that's available at Blanchard Valley Hospital. We have a plastic surgeon, Ergen Kojak, whose specialty is not plastic surgery, it is breast plastic surgery. So there are lots of different opportunities and different types of breast reconstruction. And when patients in my office ask me what's the best choice, my answer is I don't know. I mean, it is a specialty unto itself. If they said, well, what would you recommend for your wife? My recommendation would be sit down and talk to Dr. Kojak. You and he will have this discussion about the goods and the bads of the different approaches. And again, back to Adele, there is no perfect. There may be a best, but perfect is not there.
Jen, I think we have a couple of minutes. Any final questions?
Sure. If we can touch on how the Arms Family Cancer Care Center benefits from the relationship with Mayo Clinic. And then we have another question in regards to mammograms, and how often would you recommend getting a mammogram, and is it still age 40?
So I think one of the questions about mammograms, and I think we're going to put that off till the next discussion that we have. We're going to talk about diagnosis, some of the things, prevention, et cetera, and that it takes a little bit longer to think about that. So we do have a relationship with ARMS, with the Cancer Center, and with Mayo. How might that figure into either one of you two? Eric, if somebody wanted a second opinion or we have a complex case, I know our medical oncologist has presented some cases to Mayo, so I know that is an availability.
So they have a biweekly tumor board of their own that we are invited to observe. And they have specialists, both surgical specialists, radiation oncologists, and medical oncologists that participate in their own tumor board. And all of those doctors are available to us to consult with if there is a particularly perplexing case. So
and I think that's a
great opportunity.
I think it's a reasonable question to ask your doctor. If you feel, and again, we all deal with the internet, that you can find about anything you want. We'd prefer that you ask us about a question, and if we do need to get another opinion, arrangements, then things can be made. Any final thoughts, Adele?
It's such a big topic. I just want to reiterate all the support services that we have available at the Cancer Center. We talked a lot about oncology navigation, but we also have a financial navigator that can help with any of those barriers. Or financial toxicity is so crucial with patients when they're dealing with treatment payments or missing work and all the anxiety that comes into it. We also have a registered dietitian that can help with optimal health. We want people to feel good during their treatment, after their treatment. We want to focus on survivorship. We also have genetic counseling that can help inform future risk of breast cancer, especially for family members. We had spoken earlier about heredity being a portion of that. So there are a lot of extra support services, psychosocial services. For example, our cancer patient services connection, where we do healing arts programs through them. Yoga, Reiki, meditation. So we try to treat the whole person, and I think that that's what our team is about, working with one another, but working with a patient on their individual needs.
Thank you. Dr. Browning, any final thoughts?
I again would just reiterate what Adele had to share, and sort of the summary of what we've talked about is this is a cancer that's really prevalent. It has a dramatic impact on women's lives in our community. The care is complex, but the outcomes are steadily improving, and that care is available here.
Well, thank you both for being with us. We do plan to have a follow-up to talk a little bit about the diagnosis. Mammography comes up, has been asked about. We'll let you know about that. There will be a survey posted. We appreciate those of you that are on filling that out. And if you do have any questions or things you'd like us to discuss talking about breast cancer or anything else, please give us some feedback. We're glad to do this education to the community. So again, thanks to the two of you, and we will sign off.
Yeah, thanks for inviting us.
Thank you.
More than welcome.